Hello everybody and welcome to our rather strange annual members meeting, which we are, as sadly you'll have noticed, is happening everywhere. We're carrying this out remotely. We are actually very proud that we're going to be able to present some really fascinating research and other things, some highlights of the year, including some financial highlights. But we're very sorry that we're not seeing everybody in person. Thank you so much for joining us. You will get a chance to ask questions in the chat box, and I'll take some of those questions. We probably won't be able to deal with all of them at roughly 4 o'clock. So with that, I'm going to hand over to our Chief Executive, Marcel Levy. And of course, the news for him is that sadly, at the very end of March, he's leaving us to go and become Chief Scientist of the Netherlands. We'll miss him horribly, but it's very good to hear from him now. Marcel, over to you.
Marcel, you're muted, I think.
So no sign of Marcel at the moment.
Yeah, sorry, I was muted. So actually, at UCLH, can you hear me now?
Yes.
Yeah, so at UCLH, I started the rule that you have to pay £1 to charity if you speak while you're muted. So I would be more than happy to pay £1 to charity. I'm also happy to speak to you today and to present some of the highlights of the past year and a little bit looking ahead to the next year. And I hope I will be able to share my screen with you, which was working right now. Let me see. Okay, so this is the yearly overview that I usually give. And I'm only going to talk briefly about 15 minutes about the highlights of last year, which is of course a selection because there so much more happened than I can summarize in 15 minutes. I think it is almost impossible not to start with this dreadful virus, which is actually, if you look at it, a very, very small virus. It's only 1/10 of thousandths of a millimeter. So that's astronomically small. It only contains 15 genes. As a comparator, humans have 30,000 genes. But nevertheless, this very simple and very small microorganism is actually able to turn the world completely upside down. And these were the pictures that we were seeing in January 2020 coming from China. And at that time, it seemed very far away. It was a bit strange. Also, the Chinese approach was a bit strange, but not something that would immediately affect us. But that, of course, changed when the virus reached Europe, in particular Italy and later on Spain, and hospitals and intensive cares were totally overrun by very, very sick people. And then, of course, it was only a matter of time that the virus reached the UK. And this is nothing new for you. And a very difficult time started with the first lockdown in March and April. But it was not only difficult for the people and the communities that actually had to stay at home, but obviously it was also very difficult for our hospitals, including UCLH. Because we also were seeing a lot of patients who needed admission to hospital because of severe disease and a lot of intensive care admissions. Of very sick people, many of whom did not survive this very serious disease.
Marcel, I'm really sorry to interrupt you, but we can't see your screen.
Oh, that's really dreadful. Okay, I'm not sure what I can do about that.
We've now got Jim Down on the screen.
Oh, well, that was actually what I was hoping for.
Now it seems to be working. Brilliant.
Sorry, Marcel. Could you share your desktop screen rather than the presentation? That will allow you to full screen and move through the slides.
I'm sorry. I'm too stupid for this. I'm usually just do this and that works fine. So what do you want me to do? Sorry.
So when you share your content, share the desktop screen rather than presentation.
the desktop screen rather than presentation. You could speak Chinese to me and then I would understand probably better.
So on Microsoft Teams, there's the shared disk tray, and then if you share your desktop screen on Microsoft Teams.
This one.
Yes, that's correct.
But is this a presentation mode then?
Yeah, so that will work now if you full screen.
Okay. I'm just going back because I spent a lot of time making these slides, so I'm going to stubbornly show you what I wanted to show you before. So this is actually the picture of the virus. This is the picture of what we saw from China, and this is what happened in Italy, and soon thereafter what happened in the UK. And please interrupt me if you can't see what I'm saying. So there were lots of coronavirus patients in the UK, in London, and of course in UCLH as well. And we are particularly proud how the hospital dealt with all these very sick people and completely transformed itself in a very short period of time. We had a lot of people working on ITU under very difficult circumstances, as you may remember. We had to use operating theaters as intensive care space, which is really very difficult. We had many patients in the wards. A lot of war teams actually were confronted with work that they usually were not doing. We had dentists helping with deliveries of babies because the gynecologists were working somewhere else. We had surgeons who had to help on intensive care, allergy nurses who were doing virus swapping, fantastic procurement efforts from our procurement team to keep our stores of PPE at the right level so that we could actually protect our staff, admin staff that took on new support roles, a fantastic role of the finance team who actually administered all the extra costs that we were making for the reimbursement that followed later on, and maybe Tim will speak about that later on, and lots of staff working from home and thereby needed support from our IT team. So that was, with all the difficulty, a very good time for UCLH, and we could actually do exactly what we are really good at, and that's delivering healthcare to very sick people under complex circumstances. And obviously also the people in the street recognize that. It's very grateful. Here you see the rainbow in front of the UCH tower, but we also had very nice rainbow expressions, to say so, at Westmoreland Street. Right from the beginning of the pandemic, Westmoreland Street transformed itself into a cancer surgery hospital, not only for UCLH, but for North Central London and North East London. And there hundreds and hundreds of operations were done during the first lockdown for patients who needed urgent surgical intervention under completely COVID-free circumstances. And also at Queen Square, lots of activity. The intensive care saw many patients with COVID-19, but at the same time, neurosurgery and neurology just went on and was open for business for patients who needed urgent care and treatment. So I think it's fair to say UCLH at its best. And in the meantime, this was only possible because we acted as one team. Everybody was very closely working together, had one goal, and it was actually affording the best possible care for patients who needed the help of UCLH and all its staff members. At the same time, and Brian is probably going to tell about this a little bit more in detail, we did not forget that we are a research hospital and that innovation is for us one of the most important things to actually provide that very special care that you can get at UCLH. And I'm just going to show you an example. This is the team led by Mervyn Singer, our ITU physician, who actually created a new non-invasive ventilator. You may remind that there was a huge shortage of mechanical ventilation machines in the UK at the beginning of the pandemic. And with the help of UCL and its technical department, and also with the help of the Formula One team of Mercedes, they created in no time, a matter of days, and approval in a matter of weeks, and production in a matter of another weeks, 2 weeks. A new non-invasive ventilator that's now being used by thousands of people throughout the world, freely made available. I think one of the very best examples where innovation, teamwork, and science can actually be very helpful in difficult circumstances. And another example is the work that was done by Charlie Swenton, who you see here in this picture, who works both at UCLH and at the Crick Institute near King's Cross, who actually very rapidly developed new testing methods for coronavirus, which were then rolled out at an enormous scale. And up until today, 10,000s of tests are done every day for large parts of London at the Crick Institute by UCLH staff. So this is another thing we're really, really proud of. And also the third example that I'm going to give you is the work that was done at Queen Square, who were the first to realize that coronavirus was not only a lung disease, but also affected many other organs. And they did fantastic work to see, to investigate how coronavirus affected the brain, was causing stroke and other neurological conditions. And they actually presented this to a very large audience and in the very best medical journals. So in the meantime, the hospital was of course open for other services as well. I'd like to mention our fantastic maternity ward that was just, babies were not waiting for coronavirus, so they were being delivered. And we were very proud that our maternity team was actually helpful in delivering the baby of our Prime Minister and his wife in the middle of the pandemic. So I think UCLH was just doing what we can do very well, and that's delivering care. And I think it's fair to say that UCLH is just a very good hospital. And that's not just a phrase. If you look at mortality rates, this is the survival of patients who need hospitalization at UCLH year on year on year. Mortality rates at UCLH, the red dot in this slide, are the lowest of the country. And this is normalized for case mix, for complexity, for the size of the hospital and so forth and so on. Statistically significant, very, very low mortality, less than 30% than average, and even more so compared to many other hospitals if you go to UCLH. And this is something that we are all very proud of. And also in other parameters, the hospital is doing well. Here you see the friends and family test, asking people how likely are you to recommend UCLH to friends and families if they needed similar care or treatment. So this is answered by patients or people who have been in the hospital. And we score very, very high on inpatients, as you can see, even better than last year. The emergency department, which is always a difficult area, is getting better every year. And you can also see that we probably need to pay a little bit more attention in the next few years on outpatients, which is still okay. But of course, we want to be back to where we were, above 90% and preferably even above 95% in the next few years. And also the staff survey actually gives us good results. And if we ask in the annual NHS staff survey, would you be happy with the standard of care at UCLH if a friend or a relative needed treatment, we score more than 10% above the national average. And also this, of course, we can always do better, but in the meantime, these are figures we're really, really proud of. Another thing we're proud of is actually our cancer performance. You probably know that UCLH is a very big cancer center. And at this slide, you can actually see what happens if your GP thinks you may have cancer and refers you to UCLH, and how quickly you can be seen. And this is traditionally something we are pretty good at. It needs to be more than 93%. We were most of the time last year above that parameter. As you can see, a sharp drop during the COVID pandemic, but a very rapid recovery. And now we are already for months again meeting that national target. If you then have cancer, we need to make a final diagnosis and hopefully a treatment plan within 31 days. Again, as you can see, a sharp drop during the pandemic phase. But again, here we have now recovered our performance above the threshold that we need to meet, something that we're really proud of. Even more difficult is to get your treatment finalized within 62 days after the referral to the hospital, the famous 62-day cancer performance scheme. And what you can see here is that we actually met that target at the end of 2019. We then again suffered from the COVID pandemic, but with a lot of very, very hard work of all the cancer teams, our internal performance, which is the upper line here, is now back to where it should be. Internal performance means actually those patients that were directly referred to UCLH from the point of referral to their treatment. We are still struggling with our external performance, which is the lower line here, which is patients that start their journey in another hospital and then are then being referred to UCLH for their treatment. And this, of course, requires very close collaboration between hospitals, and we have good plans in place to get that back on track where we were at the beginning of 2020, because we find it really important for many reasons that cancer patients get their treatment as quickly as possible. Well, of course, last year was also the year where we started working with EPIC, our new electronic health record system. And interestingly, this was a very challenging period for the trust. It's always challenging to start a new computer program on that scale, but the EPIC program can make things really difficult. But actually it didn't happen because we had, again, fantastic teamwork of Jill Gaskin, who led the project, Mark White, our Chief Technology Officer, and a lot of people, many more than on this slide, who all worked day and night to get our EPIC system where we wanted it to be. And not only them, a very large group of people in the trust actually stood up and helped during the difficult first days and weeks of the introduction of the system, either as a super user or as a floor walker, to support everyone working with this new electronic system. And instead of being a painful period, it was actually quite a cheerful period, because the system seemed to work very well, was adopted very quickly. And of course, we had our difficulties in the first few weeks, difficulties also in getting all the patients in the right place, their appointment fixed, waiting lists well addressed, and so forth and so on. But it's only 1 year and a few months ago that we started the system, and it's now been completely incorporated in everything that we do. And we can now have come to a situation where we can actually benefit even more from all the good things that an electronic health record system can bring to our patients and can bring to our staff. Another cheerful event, of course, was that in our new ENT and Eastman Dental Hospital that was opened the year before this year started, we had a visit of Her Majesty the Queen to open the hospital in February. It was her first appearance in 2020. Unfortunately also, because of the coronavirus pandemic, her last public appearance, but we were very proud. It was actually with us, and it was a fantastic day for our staff and everybody working in the Royal National ENT and Eastman Dental Hospital. And can you remember this big hall that was created by us a couple of years ago, just at the back of the UCH Tower? Well, if you look at that side now, you can now see the most beautiful hospital building that is going to open 2 weeks from now. If you watched the BBC News yesterday, you may have seen the press conference by Simon Stevens, the Chief Executive of the NHS, given from the intensive care of this new hospital. This new hospital is having an intensive care, 8 operating theatres, more than 150 surgical beds, and more than 150 hematology beds. And it's completely COVID-free, so we are extremely proud of this hospital that will open indeed this month, at the end of this month, and can then help us to address the needs of our patients even during the pandemic. And then a couple of months later, of course, we will open the basement where the proton beam radiotherapy center is located. Speaking about buildings, this is for those of you who know the building well, this is the old Eastman Dental Hospital at Gray's Inn Road. It's now part of UCL, but we are developing together with UCL a completely new Institute of Neurology there, and it's going to look like this. It's almost like a spaceship had landed in the old Eastman Dental Hospital. It's going to be a state-of-the-art neurology center, both for research and specialized hospital care. And of course, we will miss the old Eastman Dental very much. But if you see pictures like this, this is also something to look forward to. A very nice new center where research and specialized care will meet. And we'll call it Queen Square at Gray's Inn Road. It's only 5 minutes walking from Queen Square, which is still there. But actually it is a second campus or an expansion of the neurology campus of UCL and UCLH. And having said that, I think we have come to the realization in previous years, and certainly also in last year, that UCLH cannot do anything in isolation. We need partnerships, we need working with others. One of our most important partners, of course, is the university. UCL is one of the best universities in Europe and probably in the world, but most of that success comes from its biomedical activities, and people at UCL realize that that's absolutely not possible without close collaboration with the hospital. But people at UCLH very well realize that UCLH would be less special without all the university people working in UCL. So the synergism between the two is extremely important, both for the university and for the hospital. But also our partnership in North Central London with the other healthcare providers, with community organizations, with primary care and with social care authorities is increasingly important. We have grown very quickly together during the pandemic, which has really accelerated the way we work as an integrated care system. And this is going to be very, very high on the agenda in the next few months and years, because we all realize that if we want to deliver fantastic healthcare for the people living in London and beyond, we need to do this in an integrated fashion, and we cannot do this alone. So that's what I wanted to share with you. It's a very quick and very high level overview. Much more to tell. Happy to take any questions at the end of the program today. But I think it's fair to say that the last year has been a very remarkable, challenging, but also very successful year for UCLH. Thank you for your attention.
Well, thank you, Marcel, for a great presentation. I'm sure there are going to be loads of questions which we'll take at the end. And we'll also have an opportunity to say a thank you to you. I'm going to move on now to Tim to present the annual account report. I'm unmuted. I'm not muted.
I can hear you.
You can't hear me.
I hope you can hear me. Good afternoon, everyone.
I can hear you.
Wonderful, thank you. And hopefully you can see the presentation that I'm showing. Thank you very much, Marcel, for the introduction. I'm just going to talk really quite briefly, actually, about the 1920 annual accounts, just to give you a summary of the financial performance for the last financial year. It seems a long time ago now, and a lot has happened since. But I will also, towards the end, just give a little bit of an update in terms of where we are financially this current year, and a little bit of an outlook as well. Just a reminder for anyone who has any questions, please do type them into the live event Q&A using the Teams functionality. Hopefully you can find that. We'll take questions at the end of the presentations, as Julia said, but very happy to answer any questions that you might have on finances. Time that we were in the financial regime in 1920. I'm hoping you can hear me okay. I've just got a message to say you might not be, but hopefully you can. There was a 16.2 million deficit control total that we were given. So that was the maximum deficit we were allowed to incur in last financial year. And I'm pleased to report that we managed to come in just inside of that in the end. So just under £16 million deficit for the financial year just gone. That did include some exceptional items, particularly a loss on disposal of some assets, primarily related to those technology assets that we no longer needed as a result of implementing EPIC, as Marcel described, and also a final payment in relation to the Eastman Dental Hospital, and this was payable for vacating the site and passing that across to UCL to enable that fantastic new vision of a new institute on that site. Those are the kind of headline figures. The more important number for me to focus on and for us to focus on is the underlying deficit before any of those exceptional items, and that was about £20 million at the end of last financial year. And that's the figure that, as we'll come on to, has been lost a little bit perhaps this year because of such a significant amount of change because of COVID, and we'll come back to that, I think, in terms of what the financial regime is going to look like for the NHS from next year onwards. Within that position, we had a very ambitious savings target, delivered efficiency savings broadly in line with plan. So that was about £45 million, or about 4% of our turnover as an organisation. Really important that we demonstrate that we're getting increasing efficiency out of our resources each year, enabling us to treat more patients for the same amount of money. But there was quite a reliance within that upon one-off or non-recurrent schemes. And one of the things we'll need to come back to over the coming year is how can we make sure we have a more sustainable underlying financial position. Just to mention COVID, so COVID obviously hit us in March, so the last month of 2019-20. We were funded in full for all costs that we incurred in relation to COVID, thanks to some quick intervention and new rules put in place by NHS EI and indeed the government. Those costs total about £88.6 million in March and were fully funded. And just as a reminder, some of the reasons why we have a deficit position as a trust include our private finance hospital, which is a fantastic facility, but we are still incurring really quite significant interest costs in relation to that, something that we're constantly looking at and discussing with Department of Health, NHS England, NHS Improvement. But we're also seeing a gradual reduction in the money that we get for being in a high cost location, which is called our market forces factor income, and that reduced by about £8 million in this financial year that we're reviewing here. And indeed we're scheduled to have a reduction of a further £40 million or so over the coming years to come. So that provides quite a challenging financial context for us. Just trying to move on slides. So this is the summary of the income and expenditure for the financial year 1920, about 5% increase in income from the year previous, slightly lower rate of growth than we've seen in previous years, which in some ways is no bad thing given the affordability issues that the NHS has. And indeed, we are trying to move the organisation away from a strategy of just income growth and activity growth into one where we can act as a partner about how we work together with other organisations in North Central London and beyond to become more efficient. The vast majority of that is patient care income, as you'd expect, but a significant proportion also coming from training, education and of course research, given that that is such a huge focus for us at UCLH. So just summarising that operating income in a bit more detail for you. So the patient care activities, as you can see there, saw about a 10% growth from the previous year. Education and training, we actually lost income on, and that's partly to do with losing some of the funding that we get for teaching undergraduate doctors, which is part of a multi-year programme to try and reduce the amount of cost that's going into that. Research and development was broadly flat, but we hope to see that increase in future years. And we also saw a big loss in the funding that we had been receiving for a number of years to compensate us for the financial impact of moving cardiac services to Barts Health a few years ago. And that describes a lot of the big reduction you can see there in terms of the non-patient care services to other bodies, which reduced. From an operating expenditure perspective, as you might expect, our biggest bill is on our amazing staff. We had about £595 million of staff costs in the last financial year, so that's just under half of our total expenditure. Clinical and general supplies, as you'd expect, would be is the next biggest there, and then quite a lot related to depreciation, equipment, premises, those sorts of things. Total expenditure grew by about 12% in the year. Part of that was driven by our new hospitals opening, in particular the new facility on Huntley Street for the Royal National Throat, Nose and Ear Hospital and Eastman Dental, but also because of the EHRS EPIC programme that Marcel alluded to. So just very briefly, in terms of the balance sheet position, this shows you on the top line there that we continue to invest quite heavily in our asset base. We spent about £160 million in 1920 on capital investment. It's really, really important part of our strategy to make sure we have as fresh and as efficient a campus as possible. And of course, the big investments there that relate to the majority of that 160 million are our two new hospitals, phase 4 and phase 5, or the Grafton Way building and the Huntley Street building. And that shows you kind of what's been the main move really in our balance sheet position over the year. At the bottom there, you'll see under non-current liabilities, so that's a fancy way of saying the money we owe. Most of that, about half of it, is related to the PFI itself, and the other half is borrowing that we have put in place within the NHS to borrow money from the Department of Health to help pay for some of the facilities that we've been fortunate enough to be able to invest in over recent years. Just briefly on paying patients, we have a relatively small percentage of income coming from paying patients, and this is both private patients and overseas income, and it amounts to about 2.5% of our total income in total. The bulk of the private patients, or about half of it probably, comes from our relationship that we have with HCA, private health provider. They will have some space in the new building at Grafton Way, which Marcel referred to, and we've entered into a long-term partnership with them, broadly along the same sort of lines as the one that we've had with them for some time now in the University College Hospital, and that's a really positive position for us, and we also received a capital donation from them towards the new building. But we still don't have a huge proportion of our income coming from paying patients, and one of the things we are keen to do is where we have our own consultants that are currently doing private work in other facilities, perhaps in Harley Street and elsewhere locally. If we can, now we have phase 4 opening, and if the NHS work is in no way detrimented, and that's a really important principle, we do hope to be able to bring some of that work back into UCLH and to be able to reinvest in NHS care, which of course is what we're here primarily for. So briefly, looking at the 2021 financial outlook, it's been a strange year financially, primarily because of coronavirus. For the first 6 months, all reasonable costs related to COVID have been funded by the Department of Health and Social Care, and that's brought UCLH to a break-even position, which obviously is an improvement from the year that I've just described. And that's been a really helpful regime to have in place. It's allowed us to focus on what really matters for our patients, our staff, how we can absolutely work with partners without having to worry too much about who pays for what, but just doing the right thing from a system perspective. And that's really helped to bring organisations together and collaborate in our response to COVID. From October this year onwards, that regime shifts slightly, and we now have a largely fixed funding envelope for each organisation within North Central London, and indeed for the North Central London integrated care system as a whole. Some things will still be funded on top of that, drugs and devices and so on, particularly for high cost drugs. But broadly speaking, we now have a more fixed envelope to work within. There are some movements to that. So if we manage to do more elective activity than the target that we've been set by the national NHS team, there may be some additional funding, but it's likely not to be hugely material. And there is additional funding still that we receive relating to specific COVID costs. So there's quite a lot of costs still associated with personal protective equipment for staff, for testing, of course, but also things like cleaning, security and so on, which are more expensive at the moment as we keep people safe in our hospitals. And we do still have some uncertainty in relation to the financial impact of the second COVID peak. We are waiting to see what happens, the impact of the lockdown that starts today, and what that will mean for patient numbers and COVID numbers in particular. And of course, that will potentially have an impact financially on what we have to do, what work we are able to continue doing throughout the winter that is non-COVID related. And the other thing to note is that we still don't have a completely settled position in terms of how the Grafton Way building would be funded to fully open. So we have sufficient funding to open it at the end of this month, and that's a fantastic opportunity. But we are looking to see how we can get more of that capacity funded, because I think it's exactly the time the NHS needs that additional capacity to be able to deal with some of the backlog in waiting lists and patients that have been waiting for treatment during the COVID period. So the final thing I just wanted to note is, of course, it's really important to keep close control of the underlying financial position through this period. 2021 is going to be a bit of an odd financial year, but at some point we will revert back to some semblance of normality in terms of the financial performance position and how we're held to account as an organisation. And we are trying to make sure we do the right thing. We make quick, swift decisions that are needed to treat patients that we need to make over the coming months, but always with one eye on what that means for future financial years, and what the financial funding regime might be there is still a guess to me, but lots of work going on with the national team at the moment to look at that in more detail. So that's all I wanted to say, and as I say, please do type in any questions in the live event Q&A if you have anything that you'd like to ask. Thank you.
Well, thank you very much, Tim. That was really great. Probably lots of questions on that. We're now going to hand over to Claire, our lead governor, on representing the members. So Claire, over to you. Any sign?
Julia, thank you. Is that working good?
Yes,
I'm just going to make sure I can share my slides now. Yeah. Can I just check with Jess? Are they on? Yeah. Okay, so just a bit of background first. I think on the first slide, if everybody can see it, just a reminder that there are 33 governor seats and the majority of governors are elected, and a very big thank you to all the members who voted in the recent elections. It's extremely good that you did that. Some governors represent partner organisations, so important local partners like the Borough of Camden and also like UCL, as Marcel mentioned. They have governor representatives on the Council of Governors, and I also wear a second hat. I represent the Friends of UCLH, and in the presentation I've included a link to the Friends page on the Trust website so that if you're interested you can find out more.
Sorry, Claire. See the slides. We can see the screen but not the slides, so we're just going to see if we can help on that.
Okay, well, shall I just keep chatting about the background while we're doing that, so to avoid wasting time?
But you just need to know that that's the case. Okay,
thank you. So just to say, basically the Council of Governors has three overarching duties. One is to represent the interests of the members, that's you, and of the public. The second main one is to hold the non-executive directors to account for the performance of the board. And then we have a bunch of specific duties, such as appointing the chair and the non-executive directors. We did a lot of the specific duties in 2019-20. In particular, we appointed 3 new non-executive directors. We were delighted to do so. Adam Sharples, Martin Jacobs, Simon Porter. And we reappointed Althea Effenshiley, and we also agreed that she should become the senior independent director. We're just going to see if she can load the slides up. Jane Collins, we also agreed should become the vice chair. So it's a very strong team, and we were delighted to agree those appointments. As a formality, we also received the report and accounts for 2019-20. We met the auditors, the external auditors, Deloitte, and we also reappointed them. We had to approve some changes to the Constitution to make it possible to have a senior independent director, and I'm very pleased that Althea has taken that post. One of the other specific duties that we have is to make representations on behalf of the members to the Trust about its forward plans, and we did indeed write to Marcel with 10 suggestions and received an extremely detailed reply from him in response. There was then further discussion of those ideas at a seminar which he led on plans for integration in North Central London, and that was very helpful. The second main area of the Governor's responsibilities is to deal with assurance and accountability, and I wanted to highlight one development this year, which is that there are now 2 new Board of Directors committees, one called the Research and Innovation Committee and one called the Workforce Committee. And we're very grateful to Julia and the rest of the board for agreeing that there should be governors represented on both of those committees. And that's a very good development. You'll see on the screen a very long-winded link to the statement from the Council of Governors in the quality report, and I've included that because that's actually the place to look for a more considered statement of the Council's view about the performance of the Trust in 2019 and 20. A team of governors wrote it, many of them were long-serving governors and therefore were well placed to give quite a considered view. And in particular there we highlight our view that we think the Trust delivered a phenomenal response to the first peak of COVID, and we wanted to record our thanks to the staff and to Marcel, to Flo, the chief nurse, to Brian and to Julia for everything they did to make that possible. Then part of the structure of assurance is that we have in place in pre-COVID times a pattern of quarterly meetings with the non-executive directors, and those allow us to ask questions about things that we think are important to members. So we focus particularly on EHRS and its implementation and how that was going, and it was very useful to be able to hear from Casper Woolley, who used to be a NED in that particular area. We're also very grateful to have regular sessions timetabled with Cathy Mooney, who's the Director for Quality and Safety, and that allows us to discuss the response of the Trust to some of the more difficult things like never events, serious incidents and major risks. And I have to say, regrettably, we've continued to ask for regular updates on patient transport. Things weren't so good with that before Christmas. I know things have completely changed during COVID and over the summer, and it'll be very interesting to see where that goes, but that remains an ongoing matter that the governors are concerned about. I'm just going to see if I can get to the next slide. I'd like to highlight one particular thing that happened during last year. It was the completion of a patient experience mapping project on end-of-life care at UCLH. It was undertaken by a small group, it was a governor-led project, and it had the full support of the Trust. It was initially requested by Richard Murley, who was the chair but won before Julia Neuberger. And the study methodology involved conducting in-depth interviews, one-to-one, with patients and carers. And their answers, the interviews were recorded, they were transcribed, and the governor team then spent a very long time reading, working through the transcripts to identify findings and make recommendations. So basically using patients' voices directly. Their findings and recommendations were presented to the Board of Directors at a seminar, and that was, I think, the first time that's taken place. The first time that governors have presented to the board, I should say. The wonderful Transforming End-of-Life Care team at the Trust are implementing the actions from that report, and I think it's fair to say probably that's a little bit slower than it might have been because of COVID. But the report emphasised that early conversations with patients, really good communication, and making patient choice an absolute priority are very important things. I understand from the study team that there's been an audit recently that shows that in the Trust, as a result of the study, there's now more attention to decisions that are being made previously with the patient and their family about their treatment options. And also more attention is being paid to a patient's choice about where they want to be at end of life. I think that's a wonderful study and a very valuable piece of governor work. Governors are meant to listen to members. I have to say, I think in 2019-20 it's a little bit more difficult for the council to do that because EHRS meant that some of the things that we normally didn't happen quite so often. So, for example, we had one members meet on integrated care, we had one walk round of T7 elderly care, We did collaborate in the place inspections of a number of hospital buildings that took place in November, and that was extremely worthwhile. And also we were very pleased to attend the opening by the Queen of the new building in Huntley Street. And of course we attended the two open events, the Celebrating Research open event and the Festive open event. Things got much more difficult in terms of listening to members from March 2020. We were given extremely good briefings by the Chief Nurse, the Chief Executive and the Chair, and indeed we received written weekly briefings during the first peak. And there's now been put in place a programme so that we have a special update or catch up for governors with the Chair and Chief Executive round about every 6 weeks, I think. The first one of those has been held and it's been extremely useful. But the upshot of COVID and the upshot of COVID coming on the top of EHRS being implemented is that we really do want to hear from you. It's really important that we know what members think, what sort of experience of care they have had at UCLH, and also what matters to you as members. So on the screen, you'll see that there is an email address, which is uclh.members@nhs.net. And I would like to encourage any member, please, to email in with to let us know what it is that we need to be representing to the Trust so that we can actually carry out our duties as we should do. You might also like to know that the Council of Governors meetings now take place virtually and you can join those and listen in online. And I'm told that a notice will be posted on the Trust website with instructions for how to join. And the Trust website address is down on the bottom of that page. Finally, I think on behalf of the governors, all the governors, I'd like to say a huge thank you to the staff for their absolutely amazing response to COVID-19, and massive thanks to Marcel and to Flo particularly. I'd like to thank you, the members, for supporting UCLH, for attending today. But I think one additional postscript, something you may not be aware of, is that the first peak of COVID shows that the charities supporting UCLH did a phenomenal job as well. And I've given you the link there to the page on the Trust website where you can find details of all the charities that are specifically connected with UCLH. And I would invite you to have a look at those, to read more about them, and if you like, to even join the Friends as a member. Thank you very much indeed.
Thank you so much, Claire. That was really great. And thank you so much for all the work that you've been doing. And I think it's been really hard because I know some of the governors find it very difficult to do anything remotely online. And you've been fantastic in trying to keep everybody in touch. And we're very glad, Marcel and I, to do the regular update because I do think that helps. We're now going to move to Professor Brian Williams, who's Director of Research, to talk about COVID-19 research. Don't forget, you can put questions in the chat box if you want to. I think Brian might spark quite a lot of questions, actually, with everything that's going on in research in that area. Over to you, Brian.
Hello, can you see my slides, Julia?
No, not yet.
Oh, okay, let me check again.
I can see lots of faces.
Just a minute. I did just share them. Just a moment. Oh, they're asking me to share them again. Okay, that's fine. There we go.
Yep, that looks like it. Thank you.
I'm just trying to get onto full screen. You got full screen now? Yeah,
it's fine. It's fine.
Good. Okay, so I'm going to briefly describe some of the response of UCLH in terms of our research contribution to COVID. And actually, in many ways, this has been a defining moment for the concept of the hospital being a research hospital, because I'll preface my remarks by saying that everything I'm going to describe couldn't have happened without the fact that we were already geared up to do research as an organisation. You can't do this kind of complex work from scratch without the teams and the infrastructure that we have in place. And secondly, because of the culture of research within the organisation itself. it's really interesting to think back to the first notice of this disease in the West. And this is actually the notification on the WHO website in probably not many of us would have seen as we were preparing for our New Year's Eve party on the 31st of December just last year. First time the WHO became aware that there was a new respiratory virus causing potentially lethal pneumonias in Wuhan. Now, of course, that was only 9 months ago. It's quite extraordinary to think what's happened in that time. And at that time, we didn't know what the virus was. We didn't know who was susceptible. We certainly didn't have any treatments. And as Marcel pointed out, as it ravaged across the world, we began to see some terrifying pictures in Europe, in Spain and Italy, about what might be facing us in the NHS. And this is where research comes in, because we knew so little. I love this quote, research is what you do when you don't know what to do. And we certainly didn't know what to do when we were faced with this virus back in February. In double quick time, we'd sequenced the virus in many labs around the world. We knew what the virus was. We knew how it got into the body, but we didn't know who was going to be susceptible. And it's quite interesting that a different population turned out to be susceptible than we might have expected. We had no idea what treatments might or might not work in this condition. And we hadn't even begun to think about what a vaccine strategy might look like to get us out of the disease. In fact, early on, we didn't even have a test to detect who had this virus. And as Marcel has mentioned, the collaboration that we began quite early with the Crick Institute was fundamental in getting some testing done early at UCLH. Now, what we did begin to learn very quickly was what this disease looked like. And I just wanted to show this slide to remind everybody what we learned in the first month or so of this disease, so you can see how the research played its part, as I'll describe in 3 or 4 slides afterwards. We knew this virus got in predominantly through the lungs and caused an acute viral illness. We knew in many people, or we learned in many people, that they were asymptomatic. I worked with many colleagues down in the emergency department, younger doctors who actually contracted the virus and had no symptoms at all. In others, there were a mild or a significant illness, but many people went on to make recovery within a few days or a week. But then we began to see those patients presenting in hospital, maybe 7 or 10 days after their first illness, in this phase 2 of disease. And I can tell you the research that we were doing, trying to understand this disease, the severity of the pneumonia, the really profound hypoxia, the very low oxygen levels, this incredible inflammatory response that was attacking many organs of the body beyond the lungs, and also our notification that some of these patients were developing thromboses, clots in their veins and in their arteries that were causing problems with vital organs. The other thing that we particularly noticed was that there were more men than women coming into the hospital severely ill. The people who got really ill tended to be older. We saw very few young people in the early days, and more of them had diabetes and obesity and came from our Black, Asian and ethnic minority communities. But interestingly, less than we might have expected with asthma and other respiratory diseases that we often see with flu. Many of these patients died. Some of them went to ITU and either died or recovered. And then we started asking questions. If you've recovered, are you immune? If you are immune, how long does that immunity last? Does it protect you for months or years? And then we recognized that some of the patients didn't really completely recover and are still suffering symptoms and long COVID. And we've learned all of this in the space of 6 months. And we learned so much of it because of the data that we collected on our patients and shared with other hospitals, and the discussions we had with our research community about what was going on in this disease. And we quickly realized at UCLH that 4 major things were important for us to focus on. Firstly, as Marcel mentioned, we knew we didn't have enough ventilators, and we knew we needed other ways, an intermediate way of supporting the respiration of some of these patients. We knew that we had to develop testing and improve the testing that we had. We knew we needed to develop treatments that might get some of our patients to survive where otherwise they may have not. And we also knew that we needed a vaccine or vaccines to help us out of this crisis. And just to give you an idea of the scale of the research, and I think the UK has been absolutely outstanding in the way the hospitals and the universities and the research infrastructures collaborated across the nation. So here we see the ISARIC program. This was actually developed during the swine flu pandemic and was put on the shelf, but was quickly activated as this virus appeared across the country. And this is a database registry system whereby our doctors and our nurses entered the data for all of our patients into this national registry. And very quickly, this was aggregated and used to describe the things that I've talked about. We learned about the patterns of this disease. We learned about the course of this disease. We first learned that, in fact, our impression that older male, minority ethnic groups, diabetes, obesity, were indeed the high-risk groups for these populations, and we could advise about shielding and protection. And we also learned about the kind of factors that predicted a more severe course for this disease. And this very quickly was used to inform health planning and policy. And there's a publication in the British Medical Journal of over 20,000 of the first patients that we saw in the United Kingdom within 4 weeks of them collecting the data, published for the world to read about what this disease was all about. And this kind of information continues to grow, and we at UCLH continue to contribute. Marcel's also mentioned the speed at which our intensive care team worked in collaboration with our engineers and Formula One scientists at Mercedes to produce a breathing device that was deployed at UCLH within days. You can see here, this announcement was the 29th of March. I can tell you, I went over to the lab when this was first being discussed on the 14th of March, just 2 weeks before, and this was at that time an idea. And within 2 weeks, this had gone from an idea to a device that was actually being deployed and saving lives at UCLH, then cascaded to the NHS, and the design now being used around the world for patients all over the world. We took part in a number of major clinical trials. The recovery study, which led to the discovery that a simple drug like dexamethasone could reduce death by about a quarter in patients in hospital who needed oxygen, and by almost a half in those patients who went to ITU and were ventilated. We took part in the major remdesivir trial that worked out that this antiviral was potentially useful in reducing the duration of the disease and the severity of disease. And we also recognized, as one of the first centres in the country, that thrombosis was a big problem in many of these patients and probably contributing to the death of some of them. And we immediately changed our anticoagulation protocol at UCLH and indeed on the ITU to try and reduce the risk of developing thrombosis in these patients. So within months, things that often took maybe a year or two to do in terms of setting up trials and delivering results, within months across the nation, with UCLH playing a major part, we developed new treatments for a disease that we'd never seen before, and adopted this across the nation as routine care and begun to save lives. It's quite extraordinary the pace at which this has happened. But also, when we discussed this, and I remember having discussions with Marcel about this quite early on, the only way out is a vaccine, and unless we all develop herd immunity. And very early on, when we heard about the academic programs at Oxford and at Imperial, I negotiated with those teams on behalf of UCLH to be sure that we could be playing a lead role at UCLH in the development of these vaccines. We've been one of the major, if not the major recruiter into the vaccine trials for the Oxford vaccine. And we've done first in human exposure to the Imperial College vaccine, and those vaccine studies are ongoing. And as many of you will be aware, something that normally takes 4, 5, 6 years to get to this point, that it's quite likely we will be delivering these vaccines into patients by the end of this year. It's quite extraordinary what has been achieved, and we're still testing new vaccines, and we're testing monoclonal antibodies. These are antibodies that are being designed to attack COVID that you can inject into patients directly without a vaccine. So these antibodies can do the job that your immune system would do, but can do that job in patients who don't have a very effective immune system, like people with cancer, people with HIV. And only this week, we're initiating that program of work for our cancer patients at UCLH. And finally, the diagnostics. Marcel's mentioned the early work that we did and helped with the CRIC in developing early diagnostics, which are widely used across the NHS to diagnose COVID. But we're also the first organization in the world to lead a genomics program called COG-HOKI, Hospital-Acquired Infection, whereby we immediately return the genomic sequence of the viruses as soon as the patients are diagnosed or our staff have diagnosed with a virus. And this is being used across the NHS now to try and identify outbreaks of infection from COVID in hospitals and isolate them quickly, because the genetic information can be used rapidly to tell us where the outbreak came from and who was involved. And this is going to be really important in protecting our patients, particularly in vulnerable areas. And again, it's a fantastic example of the speed of research. And finally, beyond the treatments and the ventilation and the data and the information that we've gained, we're also playing a lead role in the post-hospital management of COVID in survivors. You see here Marcel and Simon Stevens and Julia. When Simon Stevens came to announce the investment of the NHS into the long COVID clinics, and we've got one of the sort of exemplar clinics at UCLH, and we are leading the post-hospital COVID research program for London as part of the national effort, trying to answer the questions, what this is, how long does it last, and is there anything we can do to intervene to improve the symptoms of some of these patients. Just to give you an idea of the scale of the operation as I finish this, 23 of the urgent public health studies are being conducted at UCLH over the past 6 months. 32 studies that are not in the urgent health, public health bracket, but are unique studies that we're running, trying to understand the pathophysiology of the disease and data studies. Over half of these studies have been sponsored either by UCL or UCLH, which means we are leading those studies nationally. Over half the studies that are being done are being led by us from our research teams. Early on, I put together a research strategy group for COVID at UCLH. It's been remarkable. We met twice a week early on to design the studies for 2 hours each time. Over 50 investigators from UCLH and clinical scientists for UCL were part of those meetings. We have a research oversight group led by Nick McNally that has looked after the pausing of all of our non-COVID trials so that our patients are safe. We've recruited over 1,600 and now nearly 2,000 patients into UPH studies and nearly 5,000 patients and staff into all other studies. And we've had extensive patient and public involvement and the involvement of volunteers, which has been absolutely fantastic. This is incredible. In the space of 6 months, we've published now, it's actually 121 scientific papers from UCLH and UCL, from our teams, informing the world about what we've been doing and helping increase the understanding of this disease. And to show how important these papers are, there are already nearly 4,000 published citations of that work. There's been huge media coverage of our work, as has already been emphasized. And as I've mentioned, 3 areas of treatment, the CPAP, the dexamethasone, the remdesivir, are already in routine practice, improving the outcomes of patients. But we're also keen on partnership and taking the lead. And here's a lovely slide showing that the CPAP, obviously we've led that for the country. The vaccine trials were the lead in London, North London, with our hub. We're leading in London for the post-hospital COVID programme, and we're leading major data science programmes across London and indeed the nation. And we formed new partnerships with the CRIC, developing new treatments and testing, and partnerships with Birmingham, where we're linking our data with a very large centre in the Midlands to see how things are working out across both sites and improve our recruitment into trials. So this is my last slide and one of my my favourite quotes, actually, which I think is very relevant to research in this context. You can't go back and change the beginning, but you can start where you are and change the ending. And the importance of having our infrastructure, our talent for research at UCLH has enabled us to start right at the start, get things moving quickly, and hopefully change the ending by improving the outcome for patients at UCLH. It's been a phenomenal effort by so many people. It's been a pleasure to be leading that effort, but actually the effort on the ground has been just truly outstanding. And I hope you've seen what I presented, the enormous impact we've been able to make, not only at UCLH, but also in the country and around the world in improving scientific knowledge around this disease. Anyway, thank you very much.
Well, thank you very much, Brian, and a fantastic presentation. And I can just say thank you to you and actually everybody who's been involved. It's been an extraordinary effort. It's been an extraordinary 9 months actually here, seeing both clinical and research people working together, and lots of people taking no leave and working weekends and nights. It's been extraordinary, very moving and very exciting. If you would like to send in questions, please do so quickly. I've got a few questions which I will try and push to the right people to try and answer. So first of all, outpatients. Some UCLH hospitals aren't giving patients masks to wear when they arrive or when they go home. Is there a standard UCLH procedure and you must change your mask when you enter hospital? So I think I'm going to send that to Marcel.
Yes, thank you, Julia. I'm reading the question. This is actually about leaving the hospital. So the standard procedure is when you come in with your own face mask, we ask you to wear a hospital surgical mask, and we will give that to you when you enter the hospital. So we ask you to clean your hands with alcohol and to wear a surgical mask that's been provided by UCLH. When you then leave the hospital, you can just use your own face mask again, and it is not common to provide you with a new surgical mask. Actually, it's been discouraged to use surgical masks for that because we do not have enough masks to provide for everybody out of hospital. So that's something that people need to do themselves.
Thank you. And another one for you, or perhaps for Tim, are the phase 4 and 5 buildings, well, they're different. Were they and are they on time and budget? Tim, do you want to take that one?
Marcel,
yeah.
Thank you. So it's a different story for each. Phase 5 building was on time and on budget. Phase 4 is likely to come in under budget, actually, but it will be subject to some delay. And there's 2 reasons for that primarily. First of all is the complexity of the below ground proton beam therapy element. And that's why that's been delayed into next year, as Marcel said earlier. And also, of course, this year it's been phenomenally difficult to work on the sites, particularly during lockdown. And we were lucky, and our contractors, Bouygues UK, have been fantastic during that process. But that did cause a bit of further delay to the above ground component of the building.
Thank you very much, Tim. Another one for you. Why is the PFI cost still at 33 million a year when the bank rates are so low?
Yeah, great question. A simple question, a really complicated answer, but the basic version of the answer is that this was a contract that was signed over 20 years ago. We're about halfway through a 40-year contract on the hospital. At that point in time, a unitary payment was agreed, which is a total financial amount that we pay each year. And that goes up in line with the retail price index rate of inflation each year. And over time, that then grows quite significantly. And then there's a complicated formula to judge how much of that is kind of interest, how much of it is repayment on the original loan and so on. But it's that formula that is driving the £33 million interest cost, which you're right to note is exceptionally high, given the value of the building, which initially was about 400 million when it was built.
Thank you very much indeed. This one is slightly more complicated. I think I'm going to give it to Marcel, which is about whether we've met the accessible information standards, and particularly when we look at a disability, impairment and sensory loss, And for instance, with people who are deaf, and when we're all wearing face masks, it's very difficult to lip read and to understand. What's the situation as far as as UCLH is concerned?
Yes, thanks, Julia. I think that's a very good question. Of course, and as Brian has told us, we were completely, well, everything was completely new to us when the pandemic started. So in the beginning, we may have struggled to offer the most optimal services to everyone, because we had to find out ourselves what was the best option, and also not all materials were immediately available. So if we if that was a difficult time for specific patient groups, we absolutely have to apologize for that. In the meantime, we've learned a lot, and we've also found creative solutions. So, for example, when people with hearing impairments, we now, especially, for example, in the ENT hospital, we now use transparent visors, whereby you can actually see people's mouth and you can do lip reading if you're reliant on lip reading. Obviously, telephone consultations are very often very difficult for people with hearing disabilities, but we can now also do video consultations increasingly, and that makes it slightly better. And we use more and more interpreters, where we can actually overcome the difficulties that we have in communicating with our patients. I fully admit it's not ideal. Of course, we are very keen to meet all the standards of the Accessible Information Act, and we will eventually get there, and in many situations we are already there.
Thank you very much indeed, Marcel. I don't have any other questions. I thought there'd be loads of questions for Brian actually about the research presentation, but clearly not. So I'm going to close the meeting, since we were going to close in a couple of minutes anyway. But I do want to say, before we do close, a huge thank you. And I think it's really important. Claire has already said it on behalf of the governors. Various people have said it about other people they've been working with. I think it's really important for our members to know that the last 9 months has been quite extraordinary, and the effort on the part of almost everybody, well, all the staff, almost everybody, has been extraordinary and very intense. It's been a very, very moving period. This is Marcel's last meeting, last annual members meeting, so I just want to use the opportunity to say a huge thank you to Marcel, who has been a terrific leader and an absolutely extraordinary leader during the COVID-19 pandemic. It's not over yet. You're not allowed to leave till you've actually made sure it's finished and sorted. So, you know, you've just got a few things on your list. But seriously, on behalf of all the members of UCLH, a very big thank you to Marcel, and a very big thank you to everybody who supported us over the last year and more. Thank you very much, everybody, for attending, and we hope we'll be in person next year. Take care. Bye-bye.